Yeah, well, thanks for that introduction. Good afternoon, ladies and gentlemen. Welcome to Melbourne. This is really a talk on emergency airway management. However, the formal title of the project that I'm going to be presenting to you today is a prospective observational study of emergency airway management in the critical care environment of a tertiary hospital in Melbourne, Australia. And note that the manuscript is currently under peer review. Now, I'm excited to be here today to bring you a world first. This study is the first scientific evidence demonstrating that nasal prongs providing apneic oxygenation prevents hypoxemia during emergency airway management. So forget this stuff. Let's focus on a treatment now that actually might make a difference to your patients. The key messages I'm going to leave you with today are that emergency airway management is a potentially dangerous procedure and hypoxemia is a common complication. We have demonstrated in a prospective cohort study that it may be possible to prevent hypoxemia in some patients by administering nasal prong apneic oxygenation during the intubation. But before we talk more about that, we really need to set the scene. I want you to recall the last time you performed or assisted with the intubation of a critically ill patient. I particularly want you to think back to the patient where it really was not straightforward. Perhaps there was a complication such as transient hypoxemia or even cardiac arrest. Perhaps you needed a change of underwear afterwards. Could all that stress have been avoided? Emergency airway management, or the process of intubating a critically ill patient, is a high-risk procedure in the critical care environments, given the nature of their illness and their lack of physiologic reserve. The fourth National Audit Project of the Royal College of Anaesthetists confirmed that when major complications did occur in this environment, they were far more severe than those that occurred in the operating theatres, suggesting that patients undergoing emergency intubation in the emergency department and intensive care unit are very different to those undergoing routine elective anaesthesia. Hypoxemia, which is variably defined in the literature, occurs in up to 70% of patients undergoing an emergency intubation. Reducing its occurrence is likely to result in reduced morbidity and mortality. Apneic oxygenation is familiar to most intensivists, as it's commonly used during the procedure to detect brain death to prevent hypoxemia. Diffusion of oxygen down a concentration gradient from the oropharynx or trachea into the alveoli is likely to play a major role in its mechanism. In 2010, work performed in the elective anaesthesia environment suggested that in obese patients, the provision of oxygen into the nasopharynx delayed desaturation and prolonged safe apnea time. Following publication of this review, by Weingart in 2012, nasal prong apneic oxygenation during emergency intubation saw increased use. Until now, however, no scientific evidence has existed that demonstrates nasal cannula apneic oxygenation prevents hypoxemia during intubation of the critically ill. Weingart described the technique as the application of standard nasal prongs prior to induction of anaesthesia, initially with a flow of 2 litres per minute, in addition to standard pre-oxygenation techniques such as the non-rebreather bag. Once the sedative drugs are administered, the nasal prong oxygen flows increase to 15 litres per minute for the duration of the procedure. And hence the research question. In critically ill patients requiring emergency intubation, does the use of nasal prong apneic oxygenation at 15 litres per minute oxygen flow prevent the dangerous complication of hypoxemia? Well, perhaps we should ask our local vet. They seem to think so. So, to begin to answer this question, we performed a prospectively collected cohort study of all patients undergoing emergency intubation in the critical care environments of St Vincent's Hospital in Melbourne, with a particular focus on describing the patient population and our use of nasal prongs for apneic oxygenation. Ethical approval was granted by the institution's Research Governance Unit. Consecutive patients were intubated between March 2013 and February 2014. These were captured. A data collection form was completed by the team leader at the time of every emergency intubation, part of which you can see here. Data collected included patient and staff demographics, presence or absence of pre-oxygenation and apneic oxygenation, details of laryngoscopy, including the complications sustained, as well as adjuncts and drugs used. Statistical analysis was performed using STARTA version 13. Univariate analysis of associations between categorical variables was performed using the chi-squared or Fisher's exact test, and a p-value of less than 0.05 was assumed to represent statistical significance. With consecutive enrolment of patients over 1 year, we captured 139 intubations, and these were performed in 129 patients, 10 patients being intubated twice. The principal reasons for intubation were predominantly respiratory failure, overdose, altered mental status, or cardiac arrest, while the male to female ratio was 1.48. And these patients were sick. Around 50% were tachycardic or obtunded, while almost 1/3 were tachypneic and 18% already hypoxemic. Patients were predominantly aged above the age of 20 years, with a peak amongst the 30 to 39 year age group who were mostly overdose, and another among the 60 to 69 year age group who were mostly respiratory failure, while the male to female ratio was 1.48. All patients were pre-oxygenated prior to laryngoscopy. Apneic oxygenation during emergency airway management was administered to approximately 55% of patients, most commonly via the nasal prongs at 15 litres per minute of oxygen flow, as previously described. And I'll tell you about the impact of that apneic oxygenation in a moment. Few intubations were performed by anaesthetists, with the vast majority of first attempts being performed by ICU or emergency registrars. The airway was predicted to be difficult in 29 patients. However, none of these intubations were performed by a consultant on the first attempt, and only 7 of these 29 were supervised by a consultant. Overall, intubation was successful on the first attempt in 116 of 139 patients, and this is comparable to overseas data. Use of adjuncts to intubation and their contribution to success on first attempt can be seen here. Use of a stylet appeared to be more closely associated with first attempt success than the use of a bougie, and this was a significant finding. This may have implications for education and training in the institution. Use of capnography in Australian intensive care units for airway management has been reported to occur in up to 72% of intubations, while data from overseas continues to suggest low rates of use and a high incidence of esophageal intubation. We demonstrated its use in 95.7% of patients, and there were no episodes of unrecognised esophageal intubation. Complications occurred in 48 patients on the first attempt. The most common complication was hypoxemia, which we defined as oxygen saturation of less than 93%. This occurred in 24 patients, similar to prior studies. No patients had cardiac arrest following induction. There were no failed airways and no surgical airways. So what about apneic oxygenation? Well, in all comers, there was a trend towards less hypoxemia with the use of nasal prong apneic oxygenation, with a 7% absolute risk reduction, which was not statistically significant. However, in the subgroup of patients being intubated for reasons other than respiratory failure, such as sepsis or stroke or overdose, there were 0 episodes of hypoxemia in those who received nasal prong apneic oxygenation, compared to 16.7% of those without apneic oxygenation. And as you can see, this was a statistically significant result. These results persisted even when controlled for seniority of operator, duration of intubation, and number of attempts at laryngoscopy. So in other words, if you're being intubated and you have normal lungs, nasal prong apneic oxygenation appears to prevent desaturation with a number needed to treat of 6. So let's summarise. This was a prospective cohort study performed in a tertiary hospital over 12 months, capturing 139 patients requiring emergency intubation. Registrars performed the majority of intubations with a first attempt success rate that's comparable to overseas data. But the most important finding was that apneic oxygenation using nasal prongs at 15 litres per minute of oxygen flow appeared to prevent hypoxemia, demonstrated for the first time in this population. So there are several recommendations I want to leave you with today. First is that regular audit of emergency airway management should occur. Capnography should be used to confirm tube placement in every intubation. while nasal prong apneic oxygenation should at least be considered in all emergency intubations, as it appears to have an effect. And finally, prospective evaluation of nasal prong apneic oxygenation needs to be performed to evaluate the risks and benefits. So where to next? As a result of this study, it became very clear to us that a randomised control trial was warranted. Improvement in patient safety during emergency procedures is a valid goal, and this simple intervention is likely to be extremely cost-effective. It requires no new equipment, no significant training, and is likely to have a low risk of side effects. Therefore, I've designed the No DSAT trial, which stands for nasal oxygen during efforts to secure an endotracheal tube. My team and I will perform a pilot study in the emergency department and intensive care unit of 2 institutions in Melbourne, Australia. The trial protocol has been presented to the ANZICS clinical trial group, and I anticipate beginning enrolment in 2015. And now, ladies and gentlemen, I thank you for your attention. I strongly encourage you to consider the use of nasal prong apneic oxygenation in your own practice, and I'd like to invite questions.